Hello, everyone. We have a special educational event this evening in partnership with Novo Nordisk. HFA is really excited to have this interactive webinar on living with hemophilia B, challenges and hopeful futures. So I'll pass it over to our friend at Novo to get us started.
Hey, thank you so much. And I'd like to extend another thank you to Dr. Sidonio, who is presenting for us tonight, and also all the participants logging in from HFA to learn a little bit and share your experiences living with hemophilia B. Before starting the presentation and handing it off to Dr. Sidonio, just a couple of disclaimers. The following presentation does contain disease state information and is not intended as medical advice. So if you have questions or want more information, please speak with your healthcare provider. The information does not replace the advice of your healthcare provider, and Dr. Sidonio is being compensated for his time and participation on this call. Without further ado, I'll hand it over to Dr. Sidonio and let him introduce himself.
Yeah, thanks. Thanks, everybody, and good evening. Yeah, obviously want to thank Novo Nordisk for sponsoring this and HFA for partnering with them. Charles is going to pull up the slides in just a minute here. It'll just take a second. But this is, as he mentioned, this is an unbranded presentation focusing on hemophilia B. It's an educational webinar, and I'm grateful to be a part and be a medical advisor. As you can see there, I'm a medical director of the Hemophilia Treatment Center at Children's Healthcare of Atlanta and professor of pediatrics at Emory University here in Atlanta, Georgia. Next slide. If it wasn't here, I'd be outside playing tennis right now, but it is way too hot. So either way, I'm glad to be here. But we're going to talk a little bit about hemophilia B. And so obviously managing hemophilia B comes, as you know, I don't have the disease, but you know this, comes with lots of roadblocks. We're going to talk about these, and there's sort of three buckets here. So we're going to look at the challenges like breakthrough bleeds. We're going to talk about bleed protection, joint health, and physical burden of managing these issues. We'll talk next about the administrative challenges of doing hemophilia B in mainly an IV therapy world. We'll talk about vein health and the difficulties around that. And then finally, we're going to talk about the challenges of the current therapies that are available with all the peaks and troughs and all the issues associated with that. So throughout the presentation, there are going to be questions. This is very old school. You just put your answer in the webinar chat, and so we'll see it there. Through here. So the first question is, what do you feel is your biggest challenge living with hemophilia B or caring for someone with hemophilia B? So obviously there are caregivers on here and they're actual patients. And, you may have all the challenges, but which one is your biggest challenges? Is it, worrying about these breakthrough bleeds, the anxiety related to it, the physical limitations that come with hemophilia, the treatment or administrative burden, the lack of support or resources, or other? So I think you can answer in the webinar. Is that true, or is it in the Q&A? I don't see any responses yet, so I'm not sure where people can answer. But if you, I can see it if you do put it in the answer. Just go ahead and type in which one is your biggest challenge. We'll wait for the responses here. All right, I see one person type in A on the Q&A. So fear of breakthrough bleeds. We talk about that. That's hemophiliacs are going to bleed, and we can do our best to try to prevent it, but obviously, that's something we want to prevent. So yeah, I think the answers would go in the Q&A part. So let's move on. Yeah, chat's turned off, so just put it in the Q&A, and we'll have time for the next questions here, so that's no big deal. Let me just close the Q&A here. So, this next section, we're going to talk about breakthrough bleeds in hemophilia and the challenges that you may encounter with this disease. So there's lots of numbers here, and there have been a number of studies, and you may have been aware of them, but we're going to point them out here. And so we know that patients with hemophilia B bleed. We always joke about that, like death and taxes and then hemophilia X bleeding. No matter what we do, that's always going to be there, no matter how good our therapies are. We know these bleeds can be frustrating, disruptive, and even with the best prophylactic adherence, they can still happen. And so this highlights a study from 2017, from May to November of 2017, and they looked at reported bleeds and the person's number of missed doses. This was 150 patients with either moderate or severe hemophilia B that were either receiving standard half-life or extended half-life therapy. Remember, this was back in 2017. And so you can see here on standard half-life factor 9 therapy, 81% experienced bleed, while a slightly smaller number reported bleeds on extended half-life 9, or 68%. And so we know that they're happening, and we know that the therapies are good. There's a lot of thunder going on outside my window. But, the question is, the fear of bleeds still holding you back? Because we know that can happen. And we know that when there is a bleed, there was a nice paper on this years ago. When somebody had a bleed, like let's say they had a bleed on Friday, they're resting through the weekends, they're treating, they're reassessing. And so one bleed may affect 3 to 4 or 5 days before they're really back to what they can do fully. And in that interim, they may be giving 1 to 4 doses of therapy, depending what's going on, if you have with or without inhibitors. And so we know that one bleed can affect a long period of time and not just affect you on that single day. So next. So again, in the chat, so how many breakthrough bleeds do you experience, or if you take care of somebody, how many bleeds are they experiencing in a year? So just on average. It doesn't have to be, it can be spontaneous bleeds, it can be any bleeds, which just assume all bleeds. So, a nosebleed, a muscle bleed, joint bleed, any of the typical bleeds that you can see with hemophilia. So there's a Q&A button. For me, it's at the bottom on this little bar where it has, chat might be in here. So I could see we got somebody put in 1 to 2 bleeds. So that's pretty good. Most therapies, that's what they're shooting for, 1 to 2 bleeds there. So yeah. All right. So let's move on while we're doing this. Sorry, there's too many windows I got open here. So, it's not just having the bleeds, it's the worry of the bleeds, or the bother, as they say, of the bleeds. And we know that that can happen on prophylaxis. Obviously, the concern about it, having to worry about this and the anxiety. And there's a real world study found that, this is still an issue. 1 in 4, so, a pretty good number of these 66 patients with hemophilia B worried about adequate bleed protection despite whatever therapy they're on. And they agreed to this therapy, they're on this therapy, but 20% are, or 25% are still concerned about the bleeds. And while prophy might help, it's not going to prevent all bleeds. And, we're still in an era where patients will have breakthrough bleeds. And so we know that's going to be an issue. So next slide. So let's talk about probably one of the biggest challenges outside of inhibitor development. This is probably the biggest challenge, is administrative challenges. So the next slide. One of the things we always talk about is, like, we want to save the veins, right? Save the veins, because, I'll see a patient, they'll come in and we'll talk about, are you rotating the sites? They might humor me and say, yeah, I'm rotating the sites. And I look at their hand, and there's this humongous scar in this one spot on their hand. So obviously everybody has their same, their favorite spot that they like to go to. But we know that frequent IV infusions can lead to scar tissue. And obviously your veins can take a toll. They weren't meant to have metal objects stuck in there every single day or every other day or every 3 days. And so that those kind of things can add up. And so the scar tissues can make it more difficult. Having central lines could make it more difficult. There have been studies which show that when you have central lines, a lot of those veins over time become very difficult to access. Thankfully, we're not accessing and using as many central lines, or at least we're not using it for such a long period of time. But we know that scar tissue can be an issue, make it very difficult to access those your veins for infusions. A lot of people report scarring, bruising, ruptured veins as you get older. Those veins become, the bruising. You see all, presidents cover up their hands because anytime they get an IV, it's probably going to blow and lead to a bad bruise that'll be there for a while. And so these are things that happen. So next slide. So to that end, we're talking about administrative burden. We're talking about vein health. How often do you avoid administering treatment because you're worried about your veins or your loved one's veins? Some of you say, I do it no matter what. I'm a great patient. Everything's great. And then, the rest of the people are maybe more realistic where they say, yeah, I struggle with this. I skip some doses. I try. And, sometimes we know, again, you can answer in the Q&A part. People avoid treatments. They might skip a dose or they might delay it by a day because it's just too much hassle that day, or they're just not in the mood. It's too hot outside. They just want to relax, and maybe they stuck themselves twice and they're just like, I'm not going to do it. I'm going to do it tomorrow. We know that happens. And so it's something that is happening in real life. And, it's real life. We can't really blame people for this. It's tough. So we'll move on to the next slide. So, with moving, talking again about vein health, we know that years of infusions can have an impact. You can disrupt the vein, you can damage the valves associated with it. And for a younger person, it could actually lead to thrombophlebitis, superficial clots, and it could just make it harder to use over time. It can weaken the veins, weaken the valves, and then all of a sudden you just can't use that spot. And so we know that's a problem. We know that vein access issues are among the top reasons in which patients report difficulty or just downright stopping the treatment. So in this real world study, and these are in patients with hemophilia B that are experiencing, some of these issues, 40% of the people in this study said they worried about their treatment, about losing access to a vein because of taking their current treatment. How often do you feel worried about it? And so they just worry about this, just like the question you answered. And then 29% reported they had blown or ruptured veins, again, because of the treatment issues. And so I know many of you have gone through similar situations, and we can chat about that, or you can type a comment in the Q&A. But I know that people had similar situations. Sometimes people say, oh, my infusion's only twice a week. Well, sometimes they say, well, it actually takes me 3 attempts. So it's really like six, and a sticks a week. And so it's more complicated than, just writing the script. And then, on our side saying, I don't understand why they're not doing their infusions. And so we know that can be frustrating and difficult. So, next slide. I can hear the thunder outside my window here. So one of the questions that comes along is like, does administering your current treatment bring you discomfort? Obviously, you're not alone in this study of patients with hemophilia B. They were asked, is this a problem? And so 26% said they had scarring, 39% said bruising. There's a certain number that had pain, physical discomfort, and soreness. I mean, it makes sense. You're putting a metal, needle into a blood vessel, and it doesn't always work out. Sometimes it does. And so, it becomes an issue, and it's not surprising in these real world studies that people are having these issues, and just the every week discomfort of it. So, next slide. So we know that managing hemophilia B can be overwhelming. It can be frustrating, can be difficult. It can take a toll on you, it can take a toll on your family, take a toll on your sibling because, they think you're getting all the attention and you feel like it's not great. It's not the attention that you want. And you have to have supplies. You have to refrigerate some of these things. You got to take them out. You have to warm them up, reconstitute them. All these things take time. We know that, it's your school's about to start, around here in about a week. And we know it's really difficult to get, the kids fed, showered, everything ready to go. And then even thinking about doing an infusion, that's just a lot to do in the morning. If you have teenagers, they're not, very agreeable early in the morning. So we know that, if you in this study, a number of patients were at least bothered somewhat by the time it takes. They didn't like the storing the medication supplies. Some felt like there was too many steps. And then a sizable portion postponed, delayed, or just downright missed a treatment because it was just too much and they felt overwhelmed. And so the next slide is one of the questions. Which aspect of the administrative burden do you find most challenging? So you might find all these annoying, but which one is the most challenging? Is it the pain, the scarring, the bruising, the storing, any of those things? And so you can just go to the Q&A and answer there. And you can post any comments you want as well. Hopefully they're somewhat related to what we're talking about. But yeah, you can post a comment on there as well. So we know that these are issues in real world studies. I've heard this in my clinic. And, I know even just traveling to a meeting, you see people having to bring lots of supplies for the chance and the concern about, having a bleed. And so it's a real issue and something that is a problem. So next slide. So managing hemophilia can affect every part of your daily routine many times in ways that you may not realize. And for some, it's carrying the supplies, bringing the medications. I remember seeing some patients, a long time ago, we didn't have as good therapies, taking a whole suitcase, carry-on suitcase that just has supplies, needles, all the stuff in there. And so, and they're hoping that TSA doesn't look at it and think they're a crazy person, right? And so it's difficult. It's a lot to have to deal with. You can't just get your suitcase, get your little, DOP kit and get going. You got to make sure, do I have the medicine? How long am I going to be there? What if I need to move my prophy dose up? What if I have a bleed? Do I have enough to get through a bleed right there? I don't want to have to fly back. And so these are all things you have to worry about. And, in this real world study, people were bothered some of the times about carrying the medication. They were annoyed about interference with vacation. They were bothered that they had to find time to give themselves treatment. And then all of this led to stress, frustration, and anxiety. And so, this is not surprising. There's a lot that has to go into taking care of a patient with hemophilia. And, if you do everything perfect, you could still bleed. And then sometimes, you miss medications. I mean, everybody misses a sort of a Monday medication like Zantac or something. And obviously in situations like this, it could be a critical miss. And so we don't want people to do this, and we don't want people to, avoid activities because of it. So we hope that people aren't doing this. I don't know if people feel like these routines are holding them back and maybe they're not fully participating because they're just, not worried about it. Everybody has a little bit different personality. Certainly you can post it in the Q&A. And if you have a comment about it. So let's go to the next slide. So let's go into the discussion about peaks and troughs and hemophilia B therapy and the bleed protection that comes with it. So let's talk about that. And so the number of questions come up when you talk about bleed protection. And do you feel like your bleed protection is unpredictable, or you feel like, I went too hard this week and that's why I bled? It's very predictable. Or is it just like, I don't remember doing anything. I barely did anything today and I don't know why my ankle is sore. And so, factor IX therapies, when you infuse, you obviously are typically getting the levels closer to 100%, and then there's a natural decay. So the first 15 to 30 minutes, you're at the highest point, and then it slowly decays. And then, depending on your product and the half-life, before you need to give it again. And, the trough is the level right before the next dose. And so you have those periods of ups and downs. It might be good to have some good peaks, but certainly the troughs aren't the best. That's obviously something a lot of the companies are trying to do to create therapies that minimize the troughs or at least have really high trough levels. Because we know that when you go below certain thresholds, the bleed risks go up. And, this is typically around 15, 20%. Bleed risk starts to increase. You start to have more spontaneous bleeds. And so certain activities become more and more risky. So next slide. So we know that choosing protection over the participation can be a tough call. We know that people do this. And in this study that was called the B Hero study, which was the Bridging Hemophilia B Experiences, Results, and Opportunity study, it highlighted the recreational activities that happen and don't happen in patients with hemophilia B and those that are caregivers. So this was a study, and it didn't matter the gender, severity. There was a definitely reported negative impact as a result of their disease. And you can see here the number of patients. It's really interesting if you look at the caregivers and the adults, you notice that the number is higher in the moderate Hem B patients. And remember, this study is a little bit older. And so what this likely was is that most of the severe patients were on prophylaxis. But years ago, most of the hemophilia B patients, particularly young children and then older adults, often come off of it, particularly back, 5, 10 years ago. That was pretty common. And so they're not probably as well protected. And they're doing a little bit more of this sort of situational prophylaxis, which is fine, but is not as good as just regular primary or secondary prophylaxis. And so, I'm not sure if this is an issue with you. Do you schedule your activities around your infusion schedule? Do you shift the schedule around your infusions, your life around it? I'm not sure what everyone does, but certainly I know people do a little bit of the both, and this can be an issue. So yeah. Next slide. So, when living with hemophilia, obviously while living with hemophilia B has its challenges with the diagnosis and then the management throughout your life, it also means that you need to understand your limitations. I know people don't want to hear that or say that word, but there are limitations. And, it's one of those things that, patients really come to grips with. They don't want to have any limits, but we all have limits regardless of having hemophilia B. I can't play American football very well. And so there are limitations of what you can do. And so you know what they are, you maximize what you can do best. And obviously when you look for the future when it comes to hemophilia B, hopefully there are, a lot of products that are going to be coming out that can help meet you where you are. So next slide. So, if you're living with hemophilia B, we know there's value in doing your own research, but it's really important that you're getting the right information. We know the internet is full of insane amount of misinformation or misleading information, usually what it is. It's like partially right, but not the person reading it didn't really fully understand or grasp it. And the communication is really important. So there's a lot of weird information. If you look at the history of hemophilia in general, you'll see all these sort of crazy therapies that people thought worked, like peanuts. There was a period of time where somebody said peanuts were working, that bee stings that were going to work. And so, there's maybe something a little bit correct about something in that peanut protein, but obviously not enough to prevent bleeding. And so this has happened over a long time now. It just proliferates so fast because of the internet. And so it's really important that you collaborate, you work with your hemophilia treatment center, you're part of your decision-making process, you're open to think, about new therapies. The world of hemophilia is changing so rapidly. People are switching therapies on every 5-year cycles, it feels like. So I know that people are switching more often, and sometimes there's just a minor advance, but there are products that are significant improvements over the previous ones, and the goal is to obviously do what's best for you. And sometimes it's hard to, be open to those changes. And so something you want to think about, but you obviously want to have a good relationship so you can keep talking to your doctor, to your nurse practitioner, to everyone at your HTC. So next slide. And so, at the end of the day, the question is you always want to have for yourself, is your treatment meeting all of your needs? And, maybe it met your needs 5 years ago. Maybe it's not meeting your needs now. So I think it's important that you think about this. You should bring this up at your HTC. We always talk about, we always talk about making sure that patients know about all the newest therapies, even if they're doing so perfectly. They need to know about those different options because they may become an option for them later. And we know some patients store up all of their questions and information and all their concerns until that visit. And that's fine as well. So obviously you want to take a moment to think about this, but think about the advancements and, what changes might be useful for you in the future. So next slide. I don't know if you want to do this slide, Charles. This is more, related to Novo Nordisk. I can certainly do the slide, but obviously you can connect with your community liaison. There are people here available. Charles can have the QR code put up, and then have that option for you during the presentation. And so, I mean, I can go ahead and answer a question I saw in the chat, and I'm not going to use your name on here. I'm just going to read the question and then answer the question. So there's a question about hemophilia B, which is factor IX deficiency, also known as the royal disease or Christmas disease. And the question is, can you use Hemlibra to treat it? So the answer is no. The way that Hemlibra works is that, a similar drug, Mymate, and their second generation Hemlibra, they all work very similar. They mimic factor VIII. And so factor VIII is not the issue in hemophilia B. Factor IX is. There's a deficiency or defective factor IX. And so Hemlibra will do absolutely nothing for a hemophilia B patient because what it's doing is bridging the difference and activating factor X. And so the problem is there's plenty of factor VIII. It functions completely normal. So it would actually do absolutely nothing because factor VIII has a higher binding affinity, and factor VIII will bind to factor IX. Your own factor VIII will bind to factor IX well before Hemlibra will because of the higher binding affinity. So Hemlibra will do absolutely nothing for a hemophilia B patient. So good question. If there's any other questions, feel free to type it in the chat. If there aren't, that's great as well. We just wanted to have some nice educational discussion about hemophilia B, about the challenges. The good thing is there's a lot of sort of development, a lot of interest, continued interest in hemophilia. People are developing drugs. Some of them won't make it. You'll see a lot of drugs that you might have heard about 5 years ago, and maybe something happened. It just wasn't working out. They ran out of money. There was some issue with it. They just didn't feel like they could modify it and make it safe. And so a number of drugs just don't make it. And that's the way it should be. If it's not good enough, it shouldn't make it. So, but there are a number of drugs in the pipeline that are going to be targeting hemophilia B. And so I think, it's exciting to sort of see these things come to fruition. Hopefully we'll see some more drugs this year and next year become available, for our patients with hemophilia B, because they have some options, but hemophilia A certainly has maybe a few more options than hemophilia B. So we want to keep it even with your hemophilia A brothers and sisters. Any other questions? There are, just drop them in the chat. If there aren't, then, we're happy to end the night, give you right back the rest of your night. I got a milkshake, I think, waiting for me upstairs. So I'm happy to go eat that thing right now. So
Well, then, yeah, we'll give it maybe a couple more seconds if anyone does have a last minute question to put in the Q&A.
yeah.
But otherwise, again, a big thank you to everybody that spent a half hour with us on a weeknight. I know everyone's busy, and especially Dr. Sidonio for your time helping put this presentation together and presenting it with us.
All right.
So enjoy the milkshake.
Yep, I will. Oh, there's one question here I see. Let me answer it before I go. It's
Fantastic.
okay. It's not been made. It won't melt. So, so the question is about patients that are considered mild. Could they consider prophylaxis? And so that's a great question. So we're going to talk specifically about hemophilia B. We know that all of the guidelines typically align with this. So if a mild patient, a patient with a level of greater than 5% up to 50%, if they have recurrent bleeding that continues, certainly short-term prophylaxis is reasonable. I've seen this before. Patient has a joint bleed, and we go on a few months of prophylaxis because they developed a target or just a really bad, they want to recover from it. If a patient has recurrent bleeding symptoms or bleeding similar to moderate or severe patient, then certainly prophylaxis can be done. I can tell you a lot of the regimens typically aren't always the same as a severe patient, and that's okay. And so the goals might be different, and that's fine. So that certainly can happen. The next question here is, so the question is about hemophilia B patient with an inhibitor. And so let's talk briefly about that. So a hemophilia B patient with inhibitor can happen. It can happen somewhere between 5 and 10%, depends on the type and depends on the study you read. Oftentimes people have hypersensitivity all the way up to anaphylactic issues when they receive it, when they get a dose of factor IX. And we know that there is one protocol. And if you look, so the problem with hemophilia B inhibitors, it's so rare. And it's barely mentioned in the guidelines because there's only one protocol that has not been externally validated, but we all use it because, we don't have any other options, in which patients receive high doses of factor IX. They might get IVIG, they might get Rituxan, and then over time, your body slowly accepts the factor IX. We've done this at least 3 times at our institution, and it's worked. There are other times where it's just too difficult to do because the desensitization is not a fun thing to have to do. If you have anaphylaxis, you have to be admitted to an ICU. You have to run a very slow drip of incrementally larger doses of factor IX. And it can take days to get to the point where you're getting any kind of real factor IX. And then slowly your body will accept it. And this is after Rituxan, rituximab, and an immunomodulatory agent, and sometimes IVIG, and sometimes steroids. And so, there are newer medication classes that could be used for this. They target the tissue factor pathway inhibitor and that class of drug. So that isn't factor IX. It affects a specific domain of tissue factor pathway inhibitor, which improves hemostasis. And so the inhibitor is irrelevant in that situation. And so a drug that targets TFPI could be useful in that situation. So obviously, it's much easier to get that medication than go through the regimen I told you. If you have if you have an anaphylactic reaction, it's a lot of burden on the patient. So it can be difficult. So it just depends on how much time you want to spend if you really want to get rid of that inhibitor. So it's a good question. I think that may have been it.
We might have one more.
Is there? Okay.
No, okay.
Is that it? Okay. I don't see any more, so. All right. All right. Well, thank you, everybody. Hope you have a nice evening. I know it's raining a lot of places like it is here, so hopefully everybody stays cool. It's been really hot this early this week, so drink lots of fluids and stay cool.
Hey, thank you. Good night, everybody.